Okay. Hello, everyone. We have more people signing in, so we're so glad that you're joining us here this afternoon for this event. I'm Mickey Stewart. I'm the chair of the Department of Otolaryngology, Head and Neck Surgery here at Weill Cornell. That's the official name of our specialty, even though you may know us as ENT. That's a common colloquialism, but in fact, our name is Otolaryngology, Head and Neck Surgery. I'm very pleased so many people are here tonight. So many friends and patients and friends of the institution. So thank you all for being here. It's my pleasure to be joined by two members of my department we're going to be talking tonight about COVID-19, allergies and sinus, and the overlap between those, and try to clarify some of the confusion around those potential issues. This is the first in the series where our department is going to be holding more of these. I'll remind you again at the end about that. So we look forward to seeing you again for some future subspecialty topics. But tonight it's, how can I tell if it's COVID, allergies, or sinuses? I'm going to be joined by Dr. William Reisiger. He is been in our department for many years. He is both an otolaryngologist and an otolaryngologic allergist. So he's done extra training in allergy, and he manages the allergy section in our department. He does allergy testing and treatment. He teaches our residents, and in fact, he's a national leader in the world of allergy and is a co-author of some of the guidelines of how we treat allergy in our specialty. And also, I'm going to be joined by Dr. Abdin Tabai. Dr. Tabai is an otolaryngologist and a rhinologist skull-base surgeon who specializes in nose and sinus disease. He is also a national leader in our national society, the American Rhinologic Society, and is also the head of our fellowship program that we train fellows in this subspecialty area. So they're actually both quite expert in this area. So we welcome Dr. Reisiger and Dr. Tabai, and we'll be hearing from them momentarily. But I want to give some opening comments about just some of the background of what we're going to be talking about. And some of that is some of the lingo. So there is a term called rhinitis. You know, in medicine, itis means inflammation. And rhinitis means inflammation of the nose. There's a lot of things that can cause rhinitis, and there's a lot of overlap with nasal inflammation and sinus inflammation. So sinus inflammation is sinusitis. In fact, we really think that for the most part, you should call sinus inflammation rhinosinusitis, because you can't really have sinus inflammation without also having nasal inflammation. And it's a little bit analogous to gastroenteritis. Whether it's in the stomach or the intestine, you tend to have a little bit of both. So rhinosinusitis is a term if the sinuses are involved. But in fact, rhinitis is a much more common condition. We all know of one type of rhinitis, which is the common cold. That's viral rhinitis. There is such a thing as bacterial rhinitis. There's also non-infectious rhinitis. There's allergic rhinitis. We're going to be spending some time talking about that. Allergies cause inflammation in the nose and they cause rhinitis. And then there's patients who have allergic rhinitis and get a secondary infection that needs to be treated. And there's inflammatory rhinitis that is not allergic. There is non-allergic rhinitis. That is often to things that are in your environment, like, for example, cigarette smoke, solvents, perfumes, things like that. You may have a chemical sensitivity to some of those things, but it's not an allergic reaction, so that's a different type of rhinitis. The symptoms of rhinitis are varied, but they actually, are things that we've all experienced from different conditions, things like nasal congestion, nasal drainage, which we call rhinorrhea, drainage from the nose, sneezing, reduced sense of smell, pressure, fullness, nosebleed. Actually, the increased blood supply and inflammation can cause the nose to bleed. So these are all symptoms that occur with rhinitis. And of course, COVID, as we've all learned, COVID is a special type of virus that actually causes a rhinitis in many patients, and it causes a fairly characteristic pattern of rhinitis. But in fact, there's many other things, even when COVID is a prevalent condition, that also cause rhinitis. People have allergies, people have bacterial infections, they have viruses that are not COVID. So one thing we're going to try to tease out a little bit today as I talk to my colleagues and they each present to you are some of the differences in how you can really tell if you're probably having allergies, what that might feel like, how we treat allergies, also bacterial versus viral rhinitis, and also rhinitis versus sinusitis. Now, one issue is this difference between rhinitis and sinusitis. There is a common sort of commonly used phraseology or thinking among patients, which is, if I've got a cold, that's one thing, but if it lasts for a long time or if it's really bad, that must be my sinus. I've got sinus problems. And in fact, you might have sinus problems. You might have acute sinusitis, you might have chronic sinusitis. But in fact, what a lot of people have is they have a chronic rhinitis. They have an inflammatory rhinitis. It's not just because it lasts a long time or the symptoms are significant, doesn't necessarily mean it's sinusitis. So that's an important distinction to make. But people who have rhinitis, nasal inflammation, can get sinusitis and can have both at the same time. And you can have chronic sinusitis as well. So there is a lot of overlap, and we're going to try to explore some of that as I talk to my colleagues. So I'm going to start by calling on Dr. Reisiger and asking him to tell us about allergic rhinitis. And in fact, of all those various symptoms and things that we talked about, what are some of the symptoms that are key relative to, timing, severity, and what the patient might be feeling that would let you know what you're having is actually allergic rhinitis? So, Bill?
Thank you, Dr. Stewart, and I want to thank everybody also for joining. I think this is a fantastically interesting subject, particularly nowadays. This keeps us in business and keeps us very busy trying to differentiate between viruses, sinusitis, bacterial, and allergies. And I guess we'll start by saying what is allergies? What is allergic rhinitis? We've all heard these terms, and essentially what allergies are is the body's immune system making a little bit of a mistake. It's generating inflammation against something that's not really dangerous. When we're allergic to things like tree pollen, cats, or dust. Now, these things are not really dangerous to us, but for some reason, and there are some reasons that are very interesting, the body thinks that those are dangerous invaders, almost like a virus or a cancer getting into the body. And that's what allergic rhinitis is. And it produces a lot of symptoms that are really, really hard for people to get through the day with. But it's very difficult to tell the difference because there's a lot of overlap in symptoms, as Dr. Stewart mentioned, between sneezing and runny nose and cough. I had a gentleman just the other day who came into the office and he had all of those many symptoms. And I said, you know what, I think you have a virus. He said, no, I have allergies. I said, no, I think you have a virus. We went back and forth like that several times. Finally, he said, you know what, I think I'm allergic to the virus. So there's a tremendous amount of overlap with this, but there are some symptoms that are more specific to allergic rhinitis. One of the main ones is that people with allergies, they don't necessarily feel like they're ill. Okay, they may say that they're ill because everybody keeps asking them, "Are you sick?" But truly, they don't really feel sick. They don't have the symptoms like nausea, vomiting, all the symptoms that you hear about in the Pepto-Bismol commercials. They don't have those symptoms. They don't have fevers either. One of the things that they do feel, which is very characteristic of allergies, is itchiness. So if their nose or their eyes, their ears are feeling very itchy, that could be a good indicator that you might be dealing with allergies versus a cold. Also, if they're sneezing. Now, sneezing can occur with a cold, but with allergies, it's a repetitive sneezing. You're sneezing several times in a row, over and over again. So that could be indicative of it as well. Also, seasonality. If you're getting the symptoms at the same time in the beginning of the springtime for a few weeks, that also tells you through history that probably is allergies, not necessarily a cold.
So thank you, Bill. And in fact, I'm reminded of many patients who have come to see me and say things like, doctor, I get this sinus infection every April. What can we do to stop it? And in fact, what they're getting every April is seasonal allergies. And it's not actually a sinus infection. And so if you treat it with antibiotics, they're not going to get much better because they actually don't have a bacterial infection. So seasonality is an important issue. Bill, how do you treat allergies acutely for someone who just has an isolated episode? But let's say number one, and the second part of the question is, what if someone is allergic to something like dust or their pet? Yeah. And they can't just be on acute treatment all the time. What are some options for managing that long term?
Yeah, that's a good question, Mickey. With an acute reaction, meaning something that's happening right away, the first thing you want to do, if possible, is to get out of the situation that is triggering it. So, if you're outside, as soon as you can, get into an air-conditioned room, If you're allergic to cats, take the cat off your face so you're not developing symptoms. These are things you can do right away, is just to get away from it. Things like saline in the nose are helpful. Even cold compresses are available for sudden symptoms. The medications that probably work the best on an acute or a right away basis are the antihistamine medications. These are some of the tablets that are available over the counter that reduce those reactions that are caused by histamine, which is a fascinating protein that causes a lot of these problems with allergies, how it acts on the nose and the blood vessels inside the nose, causing all that sneezing and the runny nose. It's trying to get all of those things out of the nose. You know, the nose in allergy basically is like a football player. It only knows how to do two things, blocks and runs. And that's exactly what histamine does. And that's how the antihistamines are helpful. If you're allergic to multiple things and things that you really can't avoid that well, like dust, that's when we start talking about some of the other treatments like desensitization, which we're going to touch upon a little bit later.
Thanks, Bill. And I would give one more tip to people out there. That is, there's a lot of overlap between whether a medicine is an antihistamine, a decongestant, et cetera. And in fact, there's a lot of labeling by some of the companies that is a little bit confusing. And some of the same companies use the same brand to market antihistamines and decongestants, et cetera. But I've had many patients say to me, I say, have you ever tried antihistamines? And they say, doctor, I've taken every antihistamine. I said, well, which ones have you taken? Well, I've taken Sudafed, I've taken Mucinex. Well, neither of those are antihistamines. One's a decongestant and one's a mucus thinner. And so, but they thought they were taking antihistamines because, you know, Sudafed also has a brand that has an antihistamine in it. So it's very important to really understand, did you take an antihistamine or not? Some of the common brands of antihistamines are Claritin, Allegra, Zyrtec. So those are some pure antihistamines. And if it has a D on it, that means it's an antihistamine plus a decongestant.
Right. And one other caveat with the antihistamines, if you use them too consistently for long periods of time, they don't work as well. So using them on an intermittent basis when you have those acute symptoms is a good way to use it. And if you need something every single day, there are other medications, things like nasal steroid sprays, which can be used for more extended periods of time on a regular basis. So it's good to talk to your doctor and find out what combination is right for you.
And Bill, what is immunotherapy and how does that work? What's long-term allergy treatments, or what people used to say were allergy shots, but of course now we have more available than shots.
Right. Immunotherapy is actually a fantastic treatment that's been around for about 100 years, believe it or not. It's the only disease-modifying therapy we have, meaning it's something that actually makes your body less allergic, as opposed to medications, which are great, but they're symptom modifying. Immunotherapy is disease modifying. And what it is exposing your body to the very things that you're sensitive to. We have liquid extracts that have these things built into them, like dust mites or cats or tree pollen, and they're in these liquids. And if you can get them to the immune system on a regular basis over a period of time, about 4 years, the body can actually become less allergic. So you have less symptoms, you need less medications, medications work a whole lot better, and your quality of life goes up. And the benefits after 4 years of a therapy can last 20 or 30 years. Traditionally, we've done that through allergy injections, but there are some other more modern, more user-friendly ways of delivering the immunotherapy. They found that if you can get those extracts right to the lining of the mouth, instead of injecting under the skin, it gives you just the same benefit, and it's even a little bit safer. That's why in Europe now they mostly take those extracts and they drop them right under the tongue in what's called sublingual immunotherapy.
Bill, thank you. And you've been involved in some research here that was actually partially supported by some grateful patients that actually is a potentially new way of delivery of allergens. Can you tell us about that?
Yes, absolutely. So again, sublingual immunotherapy, in other words, putting those liquid extract drops under the tongue on a regular basis is great, but it wasn't great for everybody. I found that in my practice, I had a hard time getting children to do that type of therapy. It's also hard for some people to actually hold drops under their tongue and remember to do it from home because it's not a natural activity. And it also limits the area that you're applying those extracts to. So my team about a decade ago thought about this problem, and we came up with an alternate delivery system using, of all things, a toothpaste. So we were able to get those extracts, the same ones that are used for allergy shots, incorporated into a fully functional toothpaste, and people could get their immunotherapy treatment from home simply by brushing their teeth, and they could also prevent cavities and clean their teeth and freshen their breath at the same time. And Mickey, you bring up a very good point. This is exactly where the benefits of philanthropy can come in, because when we have these wonderful ideas for our patients, but they're really unproven at first, it's very hard to be able to get the funding and the money and the resources to be able to develop it further. Large government grants are hard to get for that, and even some of the smaller ones. But money that comes in through philanthropy and through the department can just get you to that next step, that next stage, so you can get that grant funding. And that's exactly what happened when we developed oral mucosal immunotherapy, is that we got some small funding, and then that led to a much larger New York State supported grant, and then that moved on to commercialization. So that is so key at that early stage of development and coming up with ideas.
So thank you, Bill, and perhaps coming to a drugstore shelf near you soon, allergy toothpaste, which is a novel way of actually doing immunotherapy. It could be quite a revolutionary change. So thank you, Bill. I'm going to move on now to Dr. Tabai. After that, I'm going to ask you to talk about smell loss in COVID. It's actually remarkable. Just as a super quick introduction, smell loss can happen, as I mentioned, from a variety of types of rhinitis. You can get smell loss from an allergy attack. You certainly can get it from common colds, etc. But we've all seen what an incredibly prevalent aspect of COVID it is, surprisingly, even amongst all the viruses. So Dr. Tabai's actually done some work in this area, is quite knowledgeable about olfaction. And so I'm going to turn it over to you, Abton, to teach us all about olfaction and the smell in the COVID era.
Thank you very much, Dr. Stewart. And thanks so much for our development team and for you, the audience members, joining us today. This is a really fun and exciting venue to be able to speak at, just sharing dialogue and hopefully some questions and answers at the end. So in a very brief period of time, I'm going to cover some of the basic physiology of sense of smell, how things work, and then, of course, the disease version, specifically focusing on COVID, but we're going to touch on other disorders that do cause olfactory loss. It's important to take a step back and say, why do we have a sense of smell and how does it normally work? It depends really who you're talking about. So in humans, we use it mostly for quality of life and enjoyment. Things that are pleasurable, food, aromas, scents are part of our daily life, even if we don't always think about it. There are some basic functional things like personal hygiene and social bonding, even for newborn babies, is in part developed based on a sense of smell. There are very specific occupations that also rely on the sense of smell. Sommeliers, food and wine people, perfume development people have a direct tie to how their sense of smell works. However, if you look at nature, the sense of smell is much more profound, and this probably was more relevant for us before fully modern evolution, if you will. It allowed and does allow animals to detect predators, to identify food sources, to identify a mate at the right time in the right place. And it does allow for certain behavior patterns that are quite complex and really interesting. You can see this in multiple different species. This is an example of the American bear, who can identify a food source and a mating source from miles and miles purely based on the sense of smell. The sense of smell is one of our special senses. It's an interplay between the outside world, the cranial nerve system, which is a part of our neural network that directly ties into the central nervous system, in this case, the brain. Sight and sound are the other commonly identified special senses. Vertigo or balance also falls into this. The sense of smell is often taken for granted. Maybe pre-COVID that was more true, but the way it works is really fascinating. So there's specific steps that happen for this to work. Odor molecules are floating and wafting through the air all the time. They eventually get passed into the nasal airway. They reach up into this part of the nose specifically. It's called the olfactory cleft. It's still part of the nose, but it has connections through little tiny neurons that eventually pass through this little bone called the cribriform plate. It's part of our skull base. Those neurons then connect with this major nerve called the olfactory nerve. It's the first cranial nerve. And then this nerve then connects with multiple parts of your brain. Parts of your brain identify the smell. It says, this is what it is. I recognize it. I've thought about it before. Other parts of your brain take it in as a deep memory so that when it comes back in your life, you can identify it again. And parts of your brain sometimes will make an emotional connection. If you ever smell your high school sweetheart's perfume or cologne 40 years later, it'll still bring back a degree of emotionality, and that's directly a neural experience that's happening. And this goes back to, again, to the animal history of liking these smells to important things, survival instincts, in fact. It turns out this experience is really, really complicated at the cellular level. There's a lot of things that are happening. And part of this experience is based on the fact that these nerve endings do specific things. Each nerve ending can identify a specific type of molecule. And when you amplify this and think about it in terms of hundreds of different possible combinations of nerve endings that then can lead thousands, even millions of different possible odor detection abilities, it's incredibly fascinating. So these are, on the left, single molecule smells. So literally one note played here will tell your brain, I'm identifying cabbage or a rotten egg, that's a sulfur smell, or garlic. But it turns out some of these molecules or olfactory experiences are based on literally tens or 15 different nerve endings being stimulated. Humans have 400 different genetic identifiable nerve ending possibilities, which means if you mix and match all those different nerve endings genetically being different, you can get up to 1 trillion different stimuli causing unique smells. We factor relatively low compared to dogs, cats, mouse, and rats, who are in the thousands of nerve endings, and their ability to smell is orders of magnitude more than ours. But it's an incredible system, and the fact that it can work is really amazing. It is interesting to note that there's some genetic variability, just like every other function and smell. Some people do this better than others, up to about a 20% difference. So there are people who smell infinitely more or significantly more sensitively and discriminately than others. And that's not a disease, it's just a variation in genetics. Like every function that we have, there's also the potential for dysfunction. So in terms of sense of smell, there are 4 different types of experiences people can have. The most common is a partial loss of smell, that's called a hyposmia. You can completely lose your sense of smell, that's called an anosmia. You can have what's called a parosmia, which is a smell is triggering an experience in your nose, but what you detect is off. So something's actually being detected, but it's not the accurate sense of smell. Often it's an unpleasant or negative sense of smell. This is often seen in people who are recovering their sense of smell. And then finally, phantosmia is that there is absolutely no smell in the environment, but you think you smell something. Your brain is being tricked. And this is often a neural or central nervous system experience. It could be Parkinson's. Certain different seizure disorders can also cause this. So as I said, COVID is not the first or last dysfunction that can cause sense of smell absence or loss. It turns out, as part of the natural aging process, most of us lose our sense of smell over time. That's probably the most common cause of loss of sense of smell. The viral hyposmia, which is what we're going to focus on in a minute, is the second most common cause, and then sinusitis in a variety of forms, whether it's allergies or polyps, can certainly impact sense of smell. There is a longer list of possible causes, some of which are listed here. These tend to be less common, thankfully. Some of these are more complicated or more permanent if they do occur. But these top 3 are the heavy hitters. This is where we see most of our patients coming from. This was a study published in a very important medical journal called Science in 1984 by one of the pioneers in smell disorders. So what they identified in a very large population is this natural decline in the sense of smell. The lower on the graph, the worse the sense of smell experience. And we can see that everyone sort of declines over time. There is a range of how quickly you can decline. Men tend to decline worse than women. Women maintain their sense of smell for longer periods of time. But as you get older, especially in your 80s and 90s, this is a very prevalent loss of function. Switching gears and focusing really on COVID, which is the main relevant thing that we talk about. COVID is not the first or last virus that can induce a sense of smell loss. These are some of the other viruses that have been identified in causing post-viral olfactory dysfunction. These tend to be common cold culprits, the things that give you a viral upper respiratory tract infection. COVID is unique in multiple ways in this situation. It's obviously much more prevalent. It's a pandemic for a reason. It's much more contagious and active and virulent. It also causes this loss of sense of smell on a higher level than previous viral agents ever did. It's also interesting in that unique to COVID is that we don't necessarily see a typical cold-like experience. You don't get necessarily a stuffy nose, a runny nose, a drippy nose, congestion, pain, and pressure. You can purely lose your sense of smell without any of that other nasal experience. We do have a long-term prognosis for other viruses. It's about 40 to 60% recovery if you do lose your permanent sense of smell, that it can come back. It can take up to a couple of years to do that. COVID data is still pending. We need at least another 6 to 12 months of follow-up data to know what the real outcome is, although we have some preliminary data. I don't think anyone in the audience is unfamiliar with COVID, but it is important to point out that loss of sense of smell is one of the cardinal symptoms identified by clinicians, by the CDC, by the World Health Organization. And in fact, it's quite common. If you do objective testing in people who show up with COVID positive tests, something like 80 to 90% will have an abnormal experience, and over 90% will actually show up on objective testing to have a loss of sense of smell. So very prevalent. Now, what's happening in COVID specifically? So one of the targets for COVID is this receptor called the angiotensin converting enzyme 2 receptor. It's present in olfactory or a sense of smell nerve fibers. It's also present in the lung, which is 2 of the common targets. And what the receptor does, it enters the cell of target, it causes injury, and then that injury causes this whole system to kind of shut down. It's interesting, it's not really the nerve that's being injured, it's some of the supporting cells, these cells that keep the nerve healthy and robust and recovering all the time. They're called sustenanticular cells. These are some of them that are listed here. And so what really it's doing on a microscopic level is injuring the home environment of the nerve itself, and then the nerve is secondarily damaged. It's interesting also to note that the nerve does have a active life cycle of dying off and recovering. It always is doing that. So we do regenerate our nerves in this part of the body, but to a degree only. If you completely wipe out the neural system here, it can't recover. There's just no base to recover from. So why is this important? The most important impact is quality of life. And it's not something you can really appreciate till you lose your sense of smell, but the life experience in a hyposmic or anosmic patient is really quite bland. That's probably the best word to use. Food is uninteresting. Going to a restaurant is only social, but not at all culinarily interesting. Wine tastes like tepid water. And it's just a smaller life, if you will. There is also the potential for harm. If you lose your sense of smell, you can't detect smoke. You can't identify spoiled foods. And so potentially you might be in danger to some degree. There is potentially, this is not as clear, but like any other special sense, if you lose it, it's telling your brain to kind of turn off that part of its function. And we do worry that cognitive decline may be linked, at least in part, to loss of sense of smell. That's unclear. We need probably longer term follow-up data. When we see patients with this presentation, we take a full history, we do an examination. Often we'll be curious to look in the nose to make sure there's nothing else going on. Very, very often it's purely just a clinical history. They tell us their story, we do an exam, and that's the diagnosis. You don't necessarily need to do complicated CAT scans or MRIs. We do sometimes involve objective smell testing. You can actually identify someone's smell acuity and see how well they can smell. That's more to do for research studies and if there's any ambiguity in the history. Mostly we're doing the history just to make sure there's nothing else that we could be missing, but for COVID, it is often a very straightforward conversation. You know exactly what caused it. I would say the number one treatment component that we provide our patients is counseling. They need a whole lot of education. I start with talking about what I spoke with you about today. How does the sense of smell work? Why is it important in your life? Why is it important in your daily health? Why is it important in your quality of life? And then we talk about some of the treatment and management strategies. We do also talk about prognosis, which I'll get into in a second. So as we've lived with COVID for a whole year now, we know a whole lot more than we did ever a year ago. This started literally a year ago, and I can tell you in my field, this was off the radar. We had no real deep perception of how COVID could interact with someone's sense of smell and what that might mean. We got early inklings from our colleagues, and we started seeing it in our daily lives. And then within a few months, we realized this is a thing. This is a real component of COVID, and so we need to investigate a whole lot of research energy, which has happened, thankfully. But there's still a lot of unanswered questions. We do know some of the prognostic indicators for sense of smell loss can be predictable. If you're younger, if you have some of your sense of smell intact, if it came back pretty quickly after the infection, If you can taste not just basic things like salt and sweet and bitter, but you can actually get flavor, those are good findings. If it's getting better over time, it's helpful. This concept of parosmia, where things are now coming in, but coming in a little off, that's also a good sign. It means your nose is trying to repair and recover. When you look at actual treatments, when we think about things like medications or surgeries or interventions, we're quite limited here. There's no actual FDA-approved treatment for olfactory loss to date. This is an active area of research, as I mentioned, but so far we're still in the early stages. We do have several studies. Many of them are not particularly perfectly designed. Many of them are what we call retrospective, meaning we look back in the past rather than doing something forward thinking. Some don't have control groups, and so we still need better data. When we think about treatment for this condition, we generally characterize it in 3 different categories. Things that are definitely harmful. So Zicam is the classic example of this. Is now off the market, but it was used in nasal preparation for a long time. The issue is that it caused sense of smell injury. So it's been proven, taken off the market, no longer a concern. There are a lot of treatments that have potential benefit but need better data. And there's one treatment that we're going to focus on that actually has been proven to benefit our patients, both in the post-viral olfactory dysfunction setting and some other settings, including surgery patients. This treatment is called olfactory training. The idea is that you can sort of nudge a nerve ending to start working if you stimulate it with whatever it needs. Stimulation in this setting is just introducing an odor or scent, and then having your brain try to make those connections again. Part of this idea is that there are nerve endings that may be less populated or fewer of them, but they can possibly do a little bit of extra work. And the other component of this is that some of the nerve endings that are trying to regrow, we want to help them grow in the right direction so that they're working properly. There are different measures of this. So something is called threshold, which is basically even a weak sense of smell, you can detect it. A weak odor in the room, you can detect it. Something called identification, that you can not only smell it, but you can tell what it is. And then discrimination. If there's multiple smells in the room, you can kind of pick up a few different ones. The idea of olfactory training is to take, in this case, 4 different essential oils or odors or scents, expose your nose to it for a brief period of time, 15 seconds or so for each odor. That's 2 minutes total. Do that twice a day, do it for a month, change up the odors every month. And then over a 6 to 12 month period, there's an expectation that if you're going to have any potential for recovery, this will help it along in a positive way. This is my last slide, and the comment here is really twofold, that this is a very big issue in my field. We deal with olfactory loss on a global scale in a way that didn't exist before. And so going forward, we're going to have a generation of people who have a significant quality of life and potentially harmful condition. This existed before COVID, but not on this scale. And so we're now looking at this in a whole new way in my field. There are a variety of different treatment avenues that are being explored. They need further research. They need funding to be direct about it. And as we, as clinicians and scientists, explore this, we view this as a very important aspect of sort of the COVID outcome, the fallout, if you will, from COVID. Many people who recover and become healthy can regain a lot of their life, but if this is a permanent loss, it's something we can intervene with, and we're working on this actively on the research front. Thank you for your time. I hope we do have some questions and answers towards the end of our session today. Thank you again.
Thank you, Epton. That was excellent. So we're going to have a few more minutes now of just some discussion amongst us, but be preparing your questions and answers. And I would encourage the participants to please put questions in the Q&A function of the Zoom meeting. And our staff will be collating those and sending them along. So I want to get to another issue, which is the sinus. So we alluded to this. I alluded to it a little bit earlier. We've heard about allergies. We've heard about rhinitis. We've heard about sense of smell. When is it sinusitis? How do you know that your cold has turned into sinusitis? And if it is sinusitis, what usually causes that, and how do you treat it? We'll start with Epton. What distinguishes it as becoming sinusitis?
That's a great question. It's an incredibly important and common question. It's something we really need to differentiate on many people in the office on a daily basis. So important to take a step back and say that there's no such single thing as sinusitis. It's a family of diagnoses. You can have bacterial sinusitis. You can have a chronic version of bacterial sinusitis. You can have polyps, which is generally considered not infectious, but still sinusitis. And then there's all kinds of weird random things that can happen. You get uncommon fungal sinusitis events that are really unique and behave in a specific way. The most commonly differentiated question that we need to figure out, when does a cold become a bacterial sinusitis event? And really, to the heart of the matter, when do you need to do an antibiotic? The symptoms overlap, and really the tell that basically nudges us to start thinking about antibiotics is the symptoms persisting more than 10 days is typical, at least a week. So things not getting better or maybe even getting worse. Typical symptoms include stuffiness, congested nose, experience thick mucus, thick secretions in the back of the throat, sometimes a cough, facial pain and pressure, fatigue, malaise are common symptoms. But you'll see that in a viral cold as well. It's really when it's persisted after a week or 10 days, or if it sort of got better and then got worse again. In our office setting, we'll also look in the nose. And so if we see typical sinusitis exam findings, swollen tissue, thick infected secretions draining out of the sinuses, at that point, we're then seriously thinking about an antibiotic course.
Thank you, Upton. And the natural history of a viral rhinitis is typically that it gets worse for about 2 or 3 days, and then it starts to get better around day 4, 5, 6. A very common scenario that patients have gone through is they've got some stuff going on in their nose. It lasts a second day. They think, if it's happening one more day, I'm calling my doctor. They call their doctor on day 3. They said, I've got congestion. I'm blowing this thick stuff out. I think I've got a sinus infection. The doctor says, I'll give you a Z-Pack. The patient starts the Z-Pack, and on day 4, they feel better. And they think, what a good doctor. I'm glad I called my doctor and got that Z-Pack. And the reality is that they'd been given some sugar pills on day 4, they were going to feel better. So the natural history, a lot of these viral rhinitis, is that around the time you would call the doctor to start the antibiotic, you're about to get better. It's when they last for multiple days and don't get better, or in fact, you get what's called double worsening. So you get sick, you're congested, you're stuffy, you're blowing stuff out, then you start to get better, then you get worse again. That's when it's become a bacterial infection. That's when you actually need antibiotics. We overuse antibiotics in this country, and much of it is this positive reinforcement we get that when we start the antibiotics, we get better in a day or 2, when in fact the antibiotics haven't had any therapeutic benefit. And you might be actually changing your microbiome when you do that. So just be aware of that phenomenon. It may have worked for you in the past, but think about whether it actually had an impact on your treatment or whether it was just the natural history of disease, which in my experience is actually much more of a common scenario.
And Nikki, one thing I've also found while on the subject of antibiotics is for viral illness is antibiotics also have anti-inflammatory properties. So many people will feel that they get a little bit better even if they have a viral illness while they're taking the antibiotics. But as soon as the antibiotics are finished, they'll say, oh, I got worse again, so I need more antibiotics. And that's, you have to be very cautious about getting on that train.
That's a great point. And particularly azithromycin and clarithromycin, those particular antibiotics actually have anti-inflammatory effects as well. So you're actually improving the inflammation, which you could have done by taking Tylenol or a non-steroidal anti-inflammatory. So Bill, you hear a lot of talk about allergies are on the rise. Allergies are increasing in frequency in the first world and in industrialized societies. Is that true? And what might be behind that? What's the thinking about this increasing prevalence of everybody, it seems, has allergies these days?
Right. And it actually is true. People have looked at this and said, well, is it really true? Are the numbers really on the rise? Or is everybody just talking about it? And that's why we think it's on the rise. And they found that it actually is on the rise. And they believe it could be due to the lifestyles that we lead. If you think about the immune system as sort of like a seesaw, at one end of that seesaw is our ability to fight infectious things like bacteria, viruses, and at the other end is the allergic type phenomenon. Okay, and that should be in balance in our lives. But if it goes out of balance, then you can have some problems. In general, we don't deal as much with infectious disease, although this past year obviously is the exception to that. Generally, we lead, compared to 50 or 100 years ago, much cleaner lifestyles. Hygiene is much better, public health is much better. We have vaccines, we have antibiotics. So our immune systems haven't had to deal as much with the infectious disease load. And what that has done is it's opened the doorway for those people who are genetically predisposed to have allergies to express their allergies. So that explains the rise.
Yes. No, thank you, Bill. If you want to read more about this, this is called the hygiene hypothesis, but it's actually been studied. So if you look in, rural China, you have a much lower prevalence of allergy than you do in Hong Kong. And if you look in rural United States versus urban areas of the United States, you see a difference. You look at, developed Western Europe versus more farming parts of Eastern Europe. I mean, this has been looked at all over the world. And in fact, the prevalence of allergies in places like New York City is higher than it was 20 or 30 years ago. It's not just that it's not just the circles you're running in. There's more allergy now, and it's this kind of misdirection of our immune system, which is kind of an interesting aspect of increasing improvements in civilization and in hygiene and things like that. So I wanted to also ask, for an acute cold, let's say you've got acute rhinitis, you're congested, you're blowing stuff out, your smell's gone down a little bit, but you don't have fever, it's just been 2 or 3 days, you don't think it's sinusitis. By the way, another finding of sinusitis sometimes is you get sort of very localized pain, like toothache pain in one cheek, or throbbing pain between your eyes. So you'll get a change in symptom that's like a localized pain or pressure, which when the nose was congested before you didn't have. You're not at that point yet, but you're still symptomatic. What can you take? What would you advise a patient to go to the drugstore and buy to actually feel better, short of calling the doctor and getting an antibiotic? After.
So couple of points. I would put on a calendar, like this is day 1 of my symptoms. I'm gonna try to ride this out for 5 to 7 days and only really seek attention if it's going in a concerning direction or not getting better after about a week. In the meantime, it's going to be unpleasant. Viral upper respiratory tract infections are quite difficult and sometimes more so. So you can take a variety of different symptom relieving medications depending on what your goal is. If you're having a low-grade fever, take Tylenol or Advil. They would both reduce your fever. If you're having pain and pressure, the same. If you're congested, you can either do a decongestant pill or a spray. The Afrin over-the-counter spray is quite helpful, but you have to limit the use after about 3-4 days. It causes a rebound effect, so you can't keep taking it. You have to stop it at that point. You can take an expectorant if you're coughing. And the reality is there's all these components are tied into things like Advil cold and sinus or NyQuil or Dayquil. They all kind of have these components in one form. And so taking one of those multi-symptom cold and cough medications for symptom relief is helpful. Resting, hydrating, potentially doing some saline sprays to wash out your nose. That's also reasonable. For the most part, it's just treading water until enough time has passed that your body can get ahead of it.
Thank you, Upton. And Bill, I get a question a lot from family and friends, which is, are these things like neti pot, sinus rinses, nasal rinses, and saline, are those okay? What would you advise patients in terms of using those, either as a general measure, like during allergy season when they're breathing in a lot of things they're allergic to, or in the presence of an acute cold?
Yeah, I'm definitely, Upton, I agree with everything you said as well. I think I'm a big fan of saline. As I always learn, the solution for pollution is dilution. So it can be very useful. Saline can come in many forms, and it depends what you're trying to do. If you're trying to moisturize more of the front of your nose, saline comes in a mist form. It comes also in a gel form, which works very nice if you tend to get that dryness right up in the front part of your nose. To be a little bit more aggressive, that comes in an irrigation form, which you fill up. It comes in a bottle that looks like a sports bottle, and you fill it up with some salt that comes from a packet, and then you fill it up with lukewarm water. I usually recommend not to try to get it around the nose to the other side. I like to tell my patients just to lean over either in the shower or over the sink, and just sort of push it just gently. It shouldn't cause any pain. To do it on one side, half on one side, then half on the other. Neti pot, the one thing I've found that I'm a little concerned with neti pots is a lot of people have get ear congestion from having it go all the way back to the opening of your ear tube way on the inside. So that's the one thing just to keep in mind. But saline, I think, is a great thing to do when you have a cold. The one thing that I find gets sometimes overused or used too long are the expectorants, which are things like Mucinex. People use those for a long period of time and they say, I don't understand why I'm coughing so much and I have so much mucus. That's exactly what they're designed to do. They're designed to promote you to cough when you really can't cough, it's too tight. And they allow your mucus to thin out and flow. So after you use those for a few days, I would leave the expectorant behind. And if you have a bad cough, go with a cough suppressant rather than an expectorant.
Well, thank you for those comments. I think in the United States, we don't use saline and irrigation as much as we should. Frankly, our European colleagues recommend these as frontline treatments. We tend to go and buy a pill that we take, whereas in fact, if you did some saline spray or irrigation, you'd also get some significant. So this has actually been studied. It's not just that it's not just like a placebo effect. It actually has a beneficial therapeutic effect of the mist or the irrigation in the nose. So we probably don't use that enough. It's very safe. And I agree, not using lots of force to try to get it all the way back to the back of the nose and causing ear symptoms. So we've got a question here in the Q&A, and it has to do with the connection between smell and taste. And I'm going to ask Apton to discuss that. But I think the important thing for everyone to keep in mind is there's a third thing to think about, and that is flavor. So you have your smell and your taste, and they come together to make flavor, which is the sensation that we get when we eat food or drink. But Apton, tell us about the connection between smell and taste, and how many people who actually think they have a taste problem have a smell problem.
Right. It's a very good question. So taste is conveyed by taste buds, if you will. They're mostly in the back of the tongue. There are 5 identified unique taste experiences: salt, sweet, bitter, umami, and I'm missing one. Sweet, salt, bitter. It'll come to me. Sour. Thank you. Sour and umami. That's it. That's the experience with taste. So when you think about taste purely and you divorce it from the sense of smell, there's actually very little flavor. It's a bland experience. And we know this from people who've completely lost their sense of smell. When you talk about flavor, so when you ingest something and you get an experience, whatever your favorite food is, your favorite drink, it's about 80% from your sense of smell. Some of that is directly going through the front of your nose, but some of it's what we call retronasal. It's in your mouth and it goes behind the soft palate and gets to the same target in the sense of smell area of your nose. Still going through the nose either way, just in a different direction. So most of flavor, in fact, is still being conveyed by your nose, up to 80% of that experience, and the rest of it's from the taste buds. So we see this in people who've lost their sense of smell completely, that their taste experience is really bland. It's just those 5 qualities and really no complex or interesting sense of flavor. COVID doesn't seem to impact taste buds. We don't see that happening. We do see sense of smell loss, but we don't see taste bud experiences being affected by COVID.
Thanks, Apton. But it's remarkable. It's absolutely remarkable how many people actually first think they have a taste problem and what they really lost is their smell. And if you actually blindfold them and put salt on their tongue, they can taste the salt. So they actually have got the taste function is still intact. So there's a question here about, for allergies, would drops rather than shots eventually lead to a cure? And are drops or shots more effective? Bill?
Great question. I get this question a lot from patients. Desensitization, as I mentioned before, is a disease-modifying therapy. So it's the closest thing we have to an actual cure for allergies. Allergy shots, as you know, have been around for about 100 years. The drops have been around for about 50 years, and now the toothpaste has been around for about 10 years. They have done some comparisons between the different methods, and so far they have not found any differences in terms of the efficacy in any significant way. The reason we do the drops in the toothpaste from home is that there is a bit of a better safety profile. So we see less of a risk of more severe reactions. So that's one advantage of some of the newer ways of delivering immunotherapy. But all the methods are really similar in the fact that they use the same allergy extracts, which are FDA approved. They just deliver them to a different area of your immune system. That's really the only difference.
Thanks, Bill. You know, there's another question that I wanted to just expand on a little bit, and it had to do with smell and taste in the context of COVID. So let me see if I express this correctly. Modify it if I need to, Apton. So with any upper respiratory infection, any rhinitis, you can lose your smell. So losing smell doesn't necessarily mean it's COVID. You can lose your smell from another type of, from a bacterial rhinosinusitis, you can lose your smell. What's unique about COVID is that the loss of smell is so prevalent. So for this particular virus causes a high prevalence of loss of smell, and often you lose the sense of smell without all the other nasal symptoms. You don't get the congestion, the sneezing, the drainage, you just lose your smell. And so I think the connection here is if you suddenly lose your sense of smell with no other symptoms, you should start thinking if you might have had a COVID exposure, because that's unusual except for COVID. If, however, you've got a cold or you start sneezing or itching, you go to somebody's house and they've got a cat and you're allergic to cats and you start sneezing and itching and you lose your sense of smell, you don't have to think, oh no, do I also have COVID? You could lose your sense of smell from allergy. Captain, is that a fair way to think about the anosmia in the era of COVID?
Yeah, no, that's exactly right. I couldn't have said it better myself. The only additional thought is that if it's a new experience for you and it's an unclear situation, often a conversation with an ENT and COVID testing might make sense, just because there's so much overlap, so much ambiguity. It's not something you should try to figure out by yourself. It could be COVID, and that's obviously important in many ways. And if it's not COVID, then there might be avenues of treatment you should be exploring anyway. It's a big deal. So if you have it, don't keep it a secret.
And that leads to another question we've gotten sent to us here, which is olfactory training done at the hospital or home? Captain.
Yeah, no, so it's designed to be a home experience. You check in with a provider every few months, but we get you set up with the idea, you buy the products yourself. It's not anything more complicated than essential oils. And we go over the protocol, why you do it. We try to really enforce the idea that it has to be done regularly for it to have improvement. No, but it's done at home as part of like your daily routine. You brush your teeth, you do the olfactory training, you move on with your day.
And actually, this is not just like marking time while things improve. It's actually been studied, and it is better than doing nothing. It actually has been shown in comparative studies to be, and if it doesn't guarantee you'll get it doesn't guarantee you'll recover your smell, but it has been actually proven an effective therapy. Question: does it work for patients with sinus polyps? Absolutely.
Yeah, great question. So this is not the first time olfactory training has been explored. We've used it in patients who've had certain types of surgeries where the sense of smell can be diminished. It's also been used in other viruses that have caused olfactory dysfunction. And yes, it has been attempted for polyps. I would say for polyp patients, it's a lot more complicated and probably a lot more individualized. It's hard to make a prediction on a case-by-case basis. The way polyps interact with your sense of smell, there's a blockage component where the air just can't get up to the sense of smell region. There's just too much soft tissue swelling in the nose for it to reach up there. And the nerve endings are surrounded by inflammation. So even if it gets up there, it's not on a molecular level making contact. So we tend to think of polyps more as targeted with medications for allergies or for surgical reduction or prednisone if it's really at a severe level. And that's kind of how we manage the sense of smell for polyp patients. But yes, it has been studied, and yes, it does have a positive impact. It's just that with polyps, there's a whole lot more we could do to go after the root cause, if you will.
Thanks, Captain. So Bill, we have a question here. I have heard that allergists are recommending taking a Claritin and a famotidine an hour before the second vaccine shot to help with side effects. What are your thoughts?
Currently, that's not a standard recommendation. So that would be something that some people might recommend to their patients and some might not. It's important to emphasize that if there is any reaction that you have right after getting the injection, the facility that you're getting it at has to have certain medications on hand that could treat any reactions that occur. So no standard recommendation at this point, but probably no harm to do that if you did take it an hour before.
I think it sounds like good common sense to me to consider, but it's certainly not an evidence-based recommendation at this point. Can you take antibiotics between COVID shot 1 and shot 2? Either one of you.
Yeah, my understanding is that it is safe to take an antibiotic. Any other like complicated medications, you should definitely check with your provider. So if you're on steroids or an immunomodulatory medications or chemotherapy, that's not straightforward. You have to have a discussion with whoever is giving you those medications. But antibiotics, from my understanding, are perfectly fine.
Right. It's not necessarily the antibiotic that's a problem either. You also have to consider the condition that you have that's requiring the antibiotics. And
Yes.
that condition may get you out of that second shot. So definitely a discussion you should have with your doctor.
Yes, very good question. I'm going to ask this question to Bill because I know he has a personal interest in it. Can patients allergic to peanuts get the COVID vaccine?
The answer is yes, you can. Yes, there's no contraindication from having any food allergies or even airborne allergies. Even if you've had a history of taking immunotherapy for your allergies, that does not interfere with your ability to receive the COVID vaccine. The allergies that we are concerned about are severe reactions you've had from other vaccines, like the flu vaccine. So yeah, so people with food allergies like peanut allergy, which I have as well, and I got the COVID vaccine, you can definitely take that. It's not going to interfere.
Thank you. There's a question here about what do we think about the low prevalence of influenza along with the COVID pandemic? Does this persist? So there's a lot of thinking about this. I'm actually interested to ask my colleagues this other a related question. I certainly think that I'm not surprised by this, frankly. I thought this would probably happen. And the reason is because of masks and hygiene and social distancing. Public health works against the flu also. So I thought we'd see less flu this year, and we have, which kind of makes sense. The other, I'm seeing my colleagues nod. The other thing that I found very interesting is I've got a lot of patients who have long-standing nasal polyps who are under sort of reasonable, medical control. Some of those patients are coming in for their checkups now after a few months, several months late because of the pandemic, and their polyps have actually gotten a little better. I don't know if you all are seeing that, but I'm seeing it. Not dramatically, but they were sort of stable for a while, and I'm seeing them now, and they're better. And I really think it's masks. I think it's people are not breathing in allergens and dust and things, and it's also hand washing and social distancing. So, nasal inflammation seems to generally be down, not just influenza. So wearing masks helps with those things as well. I don't think that necessarily means that everyone who has polyps should wear a mask for the rest of their life, but I'll tell you, it does have some benefit there are potentially some things in terms of air filters and hand washing and things like that to potentially think about going forward.
Mm-hmm. Yep. I've seen my patients with airborne allergies. They're getting they're much better because they were spending more time indoors, but the patients who are allergic to indoor allergens like dust mites and pet dander, they were doing a little bit worse.
Doing worse because of the working from home. That's a very good point, Bill. Some people who have indoor allergens have been having much more trouble because they're working from home. Exactly. And they're exposed to it all the time now. So that's a really good point. Yes. So there's another question here which we went past. Let me scroll back up to it. Just got it. We're running out of time here, but if you have nasal and sinus symptoms, how do you know whether to proceed with getting the first COVID vaccine? That's a great question, and it's a complicated question. You certainly don't want to get the vaccine when you're ill because it affects the body's immune response to the vaccine, so it won't be as effective. So generally, if you're ill, you should postpone the vaccine. Is the bottom line. If you had 2 or 3 days ago what you think was a really mild cold or a little allergy that's already getting better, you could probably go ahead and get the vaccine. But probably the better part of valor is if you're ill or think you're coming down with something, postpone the vaccine because it's not dangerous to you. It just won't work as well. If you're actually fighting an infection, your body's immune response won't be as strong. One last question, and then we're going to wrap up, and that is, what is the impact of acid reflux on sinuses? Hampton, we'll start with you.
Sure. It's a great question. It speaks to secondary factors that can affect your sinus health. Allergies is a big one. Reflux was a very sort of fashionable idea for my field for at least a decade, where everything was reflux related, including sinus disease. We think this is really important in children. A lot of the upper airway stuff that we see in children may be more influenced by reflux. The anatomy is closer. There's more of a two-way channel with the esophagus. The way they eat, digest, and so forth is not as straightforward as it is in adults. In adults, it's not a strong relationship for most people. Throat symptoms are incredibly prevalent, but sinus infections don't tend to be heavily reflux related. I would say the most common thing I see is trying to differentiate whether they have a sinus problem or a reflux problem. And it's one or the other, but not both. It's rare that a sinus issue is being heavily compounded by reflux. So it's in the neighborhood. I wouldn't say it's a common relationship.
Yeah.
Thank you. Bill, anything to add?
I agree. Tremendous symptom overlap, like postnasal drip. Although I've seen in some patients where it seems like they were possibly having some reflux all the way to the back part of the nose, just from the appearance of the tissues. So I'm leaving the door open for that. I think there might be something there that we haven't discovered yet.
It's possible, yeah, but I think it's probably in many cases it's probably true and unrelated. rather than they both can occur with the same patient.
Right.
They're both prevalent, reflux and sinonasal disease. Well, thank you very much, Dr. Reisinger, Dr. Tabai, for your contributions. I want to thank our attendees for joining us tonight. I want to thank the development team for helping to put this on, the AV team for making this go smoothly. And thank you all for your support of our department, for your interest in this presentation. I'll remind you, we have at least 2 of these coming up in the near future and probably more after that. So stay tuned for more announcements from some similar educational forums and discussions from my department in different areas of our subspecialty, like hearing loss and pediatric problems. So more things to come. But everyone have a good evening. Stay safe. We look forward to seeing everyone safe and healthy in the future.
Thanks very much.
Thanks. Good night.